also the current chair of the UK Forum on Hemoglobin Disorders since 2019. Dr. Farah will start her presentation now, please. Can you put presentation for Dr. Farah?
Assalamu alaikum. It's my very great honor to be invited to speak at the first joint meeting between the Saudi Society for Hematology and the Saudi Society for Blood and Bone Marrow Transplantation. I will be speaking about advances in the treatment of thalassemia. My disclosures are as listed, and for the agenda for the talk today, I'm going to be focusing predominantly on new treatments, gene therapy, luspatercept, and investigational drugs. There have been new guidelines for monitoring and iron chelation, and I would strongly recommend that the guidelines from either the TIF or the British Society of Hematology are referred to for advances in standard of care. So gene therapy has taken the world by storm. There has been lots of exciting developments in gene therapy, and I'll be talking a little bit about the two main companies that are developing the gene therapy product for use. There is the Bluebird Bio product, which is known as Zynteglo. This has now got conditional approval in Europe and is available in the US. And then the Vertex pharmaceutical product using CRISPR-Cas9 technology is undergoing clinical trials at this moment in time. So why is gene therapy important? Well, I think it's really important for clinicians and healthcare providers to focus on which patients this is actually beneficial for or potentially beneficial for. So my case is a 20-year-old patient with transfusion-dependent thalassemia, transfused 3 units of blood every 3 weeks and transfused from the age of 3 months. My patient receives iron chelation therapy with deferrosirox daily and has episodes of poor compliance during exams or stress. And he is on the maximum dose of Xjade at 26 milligrams per kilogram per day using the film-coated preparation. He recently had a liver iron measurement of 17 milligrams per gram dry weight and a cardiac T2 star of 9 milliseconds with a normal ejection fraction. This clearly reflects poor compliance with therapy. It clearly states that he's at risk of developing significant cardiac complications, including heart failure, because he does have cardiac iron overload, and he is seen by a psychologist for help and support with compliance. We know that the average life expectancy for thalassemia patients is around 60 years of age with well-controlled iron burden at expert centres, but this does not hold true at non-expert centres or where the iron burden is poorly controlled. So what is the process for gene therapy? Well, in the clinical trials, and in fact, in reality, the patient will undergo screening. They will, if they pass screening, have a stem cell collection. Those stem cells will go off and be modified. And if it's using a CRISPR-Cas9 type technology, there will be isolation of CD34 cells followed by CRISPR-Cas9 gene editing. And then the stem cells are frozen and undergo a quality control assurance process. If it's a gene therapy, gene insertion strategy, such as that used by Bluebird Bio, the CD34 cells are transduced with the lentiviral vector, and then they are cryopreserved. The patient then returns to the hospital once the quality control checks are good enough and undergoes busulfan conditioning, followed by infusion of the stem cell modified product. And we then wait for engraftment, deal with any of the complications a patient gets as part of the conditioning or as part of the neutropenia. And then they're discharged from hospital and undergo long-term follow-up. The gene therapy clinical trials with Bluebird Bio are the most advanced, and patients are now in long-term follow-up studies. And what we know from the long-term follow-up studies is that there are two primary cohorts of patients: those who were transplanted in the early part of the clinical studies in the HGB 204 and 205 clinical trials, where there wasn't significant modification in the transfection process. And then there's the patients who were transplanted as part of the 207 and 212 studies, where the transfection process had been refined and we were getting much better stem cell transfection. The long-term follow-up study into which all of these patients have been enrolled is the long-term follow-up 303 study, and it's looking at the levels of HbA T87Q and the total hemoglobin levels, the degree of transfusion independence a patient has, and biomarkers of ineffective erythropoiesis. They're also monitoring iron burden and long-term safety of the patients. So the patient characteristics prior to enrolling into the LT303 study, if we look at the phase 1/2 patients, was that their average pre-red cell transfusions with phase 3 patients in the other 2 studies was very similar. Liver iron concentration was a little bit higher. Cardiac iron levels were similar, but the key take home here is that the vector copy number for the patients in the phase 1/2 studies was only 0.8, and it was 3.2 in the patients in the phase 3 studies. So the level of transfused cells is almost 3 times higher in the phase 3 study patients. So this is why it's really important for us to look at what is happening with the patients over the long term, as there is a concern about the phase 1/2 patients possibly not having as good a hemoglobin in the long term as the patients in the phase 3. So all the patients are alive at last follow-up. There's been no Beticel or Zynteglo-associated adverse events at 2 years post-infusion, and no vector-derived replication concerns around the lentiviral vector. The durability of transfusion is maintained over the long term with these patients. And what you can see here is that in the phase 1/2 study, you've got patients who've at the highest are running a hemoglobin of about 13.1, but there's pretty stable hemoglobin levels around about 100. And in the phase 3 study, you can see here that the baseline hemoglobins for these patients are many times better. What we know about the markers of ineffective erythropoiesis is that the soluble transferrin receptors and the endogenous erythropoiesis is significantly better for the patients. And if you're looking at the iron burden, of course, post-transplant, this is expected to go down in the absence of ongoing transfusions and with the intervention using either phlebotomy or iron chelation therapy. The data from the CRISPR-Cas9 gene editing trial again shows pretty good data. What you have here is 2 clinical trials that are running. There's the thalassemia trial and there's a trial for sickle cell patients. This is data from last year presented at ASH and EHA. And what you can see here is that there's a variety of patients with thalassemia who have got beta plus or beta 0 mutations and pretty reasonable transfusion iron burden. The time for neutrophil engraftment was about 32 days and platelet engraftment was about 37 days. There's been no serious significant adverse events. 2 patients have had a total of 5 SAEs. 1 has had veno-occlusive liver disease. Well, in fact, 2 have had veno-occlusive liver disease, and there's been an episode of febrile neutropenia and colitis. 1 patient had 4 SAEs possibly related to the product, including hemophagocytic lymphohistiocytosis and acute respiratory distress. That patient is also doing very well clinically in the long-term follow-up. The really good point here with the gene therapy results is that you can see that patients have got extremely good post-transplant hemoglobins, and they are all now transfusion independent post-transplant. The pancellular expression of hemoglobin F, because the CRISPR-Cas9 product basically does gene editing to promote the production of hemoglobin F. And what you can see is that the hemoglobin F production is pancellular and produced at good levels. Now, this is extremely important, obviously, for people with sickle cell disease. Now, what you can see here is the duration of transfusion independence after the insertion, after the gene therapy editing using CRISPR-Cas9. And you can see that transfusion independence is certainly appearing to hold throughout the patient's journey. With luspatercept, this is obviously now a licensed product in parts of Europe and also in the US. It's not a licensed product at the moment in the UK. Luspatercept is a first-in-class erythroid maturation agent that neutralizes selected TGF-beta family superligands to inhibit aberrant SMAD2/3 signaling and enhances late-stage erythropoiesis. The BELIEVE clinical trial was a placebo-controlled phase 3 clinical trial, and it's got a long-term follow-up period now. And we're looking at periods of transfusion reduction of a significant degree within a fixed time point and also at rolling data as part of the study. In the BELIEVE trial, 224 patients were randomized to receive luspatercept, and 47, that's 21%, achieved a significant reduction of 33% from baseline between weeks 13 and 24, and those were the ones that were defined as luspatercept responders. Of the 177 patients who didn't achieve a 33% reduction, those were defined as non-responders, and that was because of the way the study had been designed. However, about 40% of patients do respond to luspatercept outside of the fixed time window. So if you look at the rolling data, that actually shows a good response. So luspatercept responders and non-responders, more than 50% reduction was seen in 62 patients, that's 38% on the rolling data, and 73% of patients, in fact, on ongoing longitudinal data had a good response with luspatercept. And there was a reduction in serum ferritin in the responding arm for patients across the board as well. Side effects with luspatercept are relatively minor, no serious adverse events. However, in the clinical trial, patients did complain of bone pain, which was seen in quite a few, along with muscle pain, again seen in quite a few patients. Now, the exciting bit of work here is the new drugs. So there is a lot of literature coming out now from Southeast Asia on the use of thalidomide. And I'm going to talk about two particular clinical studies, one of which I've reviewed, which showed really excellent, promising data. So there's 71 patients in the study published by Yang et al. Who, with duration of therapy of over 3 months and follow-up data, these patients were recruited into a trial on the basis of the fact that they had to suffer from transfusion-dependent beta thalassemia, but were unable to afford regular transfusions or iron chelation. Patients had to be between the ages of 14 and 65, and they were excluded if they had liver, renal, cardiac, or pulmonary problems or a history of thrombosis. The key take home here for these patients is at 12 months, these patients had developed transfusion independence, going from a baseline hemoglobin of 70 to a hemoglobin of 100.2 at the 12-month mark, with that's in the non-transfusion dependent patients, and in the transfusion dependent patients then gone from a hemoglobin of 5.6 pre-transfusion to a hemoglobin of 9.1 in the post 12-month follow-up. This is really excellent data in this population. And then in the non-transfusion dependent patients, the serum ferritin had appeared to have risen in those patients as it had in the TDT arm. And this actually does need a little bit of follow-up to see what's going on in these patients and whether that's genuinely increase of iron or whether that ferritin is actually reflecting the mobilization of iron from the hemosiderin form to the ferritin form as it's being used for erythropoiesis. The second study is a prospective interventional single center study with 45 patients with E-beta thalassemia, and the patients were divided into 3 groups. Group 1 was thalidomide and folic acid. Group 2 was hydroxyurea and folic acid, and Group 3 was folic acid on their own. The patients were followed for 12 months, and the response was counted as being a rise in the hemoglobin of more than 1 gram per deciliter, and 66% of patients were major responders with a hemoglobin of more than 2 grams per deciliter. Transfusion reduction was significantly better in Group 1, which is the thalidomide and folic acid group, 100%, compared to 34% in the other groups, and no serious adverse events were reported in these patients. There are other drugs that are currently being looked at, but these are hepcidin mimetics and similar agents. La Jolla undertook a clinical trial using a synthetic hepcidin. The trial, in fact, closed early because it didn't meet primary and secondary endpoints. There is an ongoing study using VIT-2763, which is a ferroportin inhibitor, looking at multi-dose PK in the US. And then Protagonist is doing a study using an injectable hepcidin mimetic peptide in people with beta thalassemia and other disorders. And then Silence Therapeutics is looking at a study using TMPRSS6, and healthy volunteer studies have been completed. And the plan is that there will be phase 1, phase 2 studies starting up in patients with thalassemia syndromes. Active clinical trials, which are in phase 2 and 3 with investigational drugs, are currently the IMARA study, which is known as FORT, and that's a phase 2 study using a PD-9 inhibitor, which is an ongoing active trial. It's literally just finished recruiting into the non-transfusion dependent arm, and the transfusion dependent arm was fully recruited into by summer of 2021. And then there's the AGIOS study using mitapivat, which is a phase 3 clinical study in patients with thalassemia and sickle cell disease. And I'll talk quickly about IMARA and about mitapivat. IMARA is a PD-9 inhibitor. It works by increasing cyclic GMP levels, which is associated with a reactivation of fetal hemoglobin. So that's the reason why it may be useful in people with sickle cell and in people with thalassemia. Increased levels of hemoglobin F obviously have been associated with increased red cell survival in these patients. Now, IMARA has been used extensively in the sickle cell clinical trial, and the side effect profile that I'm showing you is from the sickle cell trial, and hence the VOC events are being described. But if you look at the side effects, it's actually really not significant side effects in comparison to people on hydroxyurea. So the FORT study is a study of 44 weeks duration, 4 weeks of screening, 36 weeks of treatment, and 4 weeks of follow-up with study visits every 3 to 4 weeks. And we're awaiting, obviously, the results of that trial, but the trial is now closed to recruitment. And I would hope that we will have interesting data coming from that trial. Mitapivat is an activator of red cell pyruvate kinase. Pyruvate kinase is a really important enzyme involved in the glycolytic pathway here. And what the pyruvate kinase isoenzymes do in the red cell is that they are involved in the glycolytic pathway, and they actually catalyze the final step in the catalytic pathway. The benefit of having an increased pyruvate kinase enzyme level is that you get an increase in the amount of ATP, and you therefore then get better red cell survival. The clinical trial that is starting up for mitapivat in thalassemia is actually really very interesting. It's called the ENERGIZE study. There are two parts of this study. One is for non-transfusion dependent patients, and the other part is for transfusion dependent patients. The really interesting thing about the non-transfusion dependent patients is that in this study, alpha and thalassemia, beta thalassemia non-transfusion dependent patients can be recruited. It's a placebo-controlled randomized trial looking at BID dosing of mitapivat orally against placebo for 24 weeks, and then a long-term follow-up using mitapivat for 5 years. The transfusion-dependent arm is very similar. What we do know from the phase 2 open label multi-center study is that the results are actually looking pretty promising, and hence the move to the phase 3 study. In the phase 2 study, what we had was that patients were receiving mitapivat, and of 20 patients who received mitapivat with a baseline hemoglobin of 7.9, at week 6, the patients had escalated their dose to 100 milligrams BID. And what you can see is that there was an increase in the hemoglobin of at least 1 gram per deciliter for these patients. And very interestingly, out of the patients with transfusion with beta thalassemia, 65% of patients responded, but with alpha thalassemia, there was also a really good response observed. This is the graphs showing the response in the increase in hemoglobin compared to baseline, showing that almost all the patients had an increase in their hemoglobin in comparison to baseline. And in fact, the alpha thalassemia patients had a very good response as well from their baseline hemoglobin. So I just want to say thank you very much for inviting me to speak at the meeting today. It was my very great pleasure and honor, and I'm very happy to answer questions in the Q&A session.
Thank you, Dr. Farah, for the excellent coverage and presentation of the thalassemia and the advances in the management. We will keep the question till the end of the session, and I'll give the microphone to my colleague.
Assalamu alaikum. My pleasure to introduce the second speaker, Dr. Suad Al-Jaouni. She is a professor consultant of hematology and professor consultant of pediatric hematology oncology, faculty expert and senior research at hematology department, Faculty of Medicine, King Abdulaziz University Hospital and Tertiary Care Medical Center, King Abdulaziz University, Jeddah, Kingdom, with more than 30 years experience in hematology, pediatric oncology. She has more than 230 publications in the respectable journal and prohibited medicine research. She is a member of editorial movement board of Journal of Applied Hematology. She is well known dedication active role in education and research on blood disease, nutrition, cancer research, and natural product research. So, Dr. Suad, the floor for you.
Thank you so much. Thank you so much. السلام عليكم ورحمة الله وبركاته. في صوت؟ It's my great pleasure to be here in the 20 Society of Saudi Society and the bone marrow transplant, a joint conference. I would like to thank the organizing committee and the scientific committee to let me join this important conference. Today, I will get you the journey from our research and clinical studies in our department. The presentation, please. Okay, if you can give me 15 minutes for the journey for 30 years, I'll hope you'll give me more minutes. Okay. The outline for my talk will say about precision medicine in thalassemia. To go for this journey, we need to see first
the prevalence of thalassemia gene in our country, and especially in our area, the natural history of the disease, which is very important, disease complications and morbidity, and how to decrease the morbidity in thalassemia, and early detections of iron overload, which is cause all the complication in thalassemia, and how to detect it in the heart and the liver, and how to decrease the morbidity. And we focus on splenectomy and the morbidity and how to avoid splenectomy. And there is a new things and concept about chronic pain. It's a common complication in thalassemia. Is there a novel therapy to improve the quality of life for chronic pain? The aim, like usually with any disease, you would like to put a potential for precision medicine. It's a wellness. Wellness vision is very important for any disease. Improve the quality in diagnosis and management, and improve the patient outcome, quality, and patient satisfactions. The potential for precision medicine usually to give a wellness, early detection of disease risk, and this is thalassemia. It's a disease of a chronic side effect, prevention of disease complication, and try to put a plan for individual patient, and also to be safe, predict the safety for a new therapy or any medications, and other things to minimize the serious side effect. This is my disclosure. As you know, Saudi Arabia has different areas with different percentage of the disease. If we concentrate in Mecca region, Jeddah, we found alpha thalassemia 40%, beta thalassemia 3.5%, hemoglobin E 2%, and sickle cell 5.2%. And this is very important to know the prevalence in your area, and you see the difference between south and east, and how prevalence of all over the kingdom. If we look for over incidence, some areas in Saudi Arabia have high percentage. This is very important to know because like alpha thalassemia, 40% in our area, and we don't see much like hydrops fetalis, because our study shows the majority of our patient is a silent carrier of alpha thalassemia, and which I put the star, and thalassemia 1, which is alpha plus. I put this picture because of premarital screening, very important, sometimes missed the beta thalassemia trait because of accompanied with iron deficiency anemia. As you know, beta thalassemia major, it's no hemoglobin A, and also they require the transfusion less than 2 years of age. And this is a picture of beta thalassemia with a lot of nucleated cell and target cell and ghost cell. This, all the time I put it, this is the natural history of the disease. We divide it to parts. If you look for the first part, it's anemia. Anemia with their complications and be treated with blood transfusions. Blood transfusions, there is another risk factor, iron overload, and you see the complication of iron overload. So they need to have follow-up safety and efficacy. Then we go to chelations. We have 4 types of chelations, and each one has own side effect. The last, which is the stem cell and gene therapy. More important for chelations therapy is like detoxification of rapid get out from the iron, extra and intracellular, and the other more important for me, acceptable toxicity and prevent oxidative stress damage. The first study, we did it in our center, and we follow our patient for 14 years. what we found, the summary of causes of death, because like you would like to know what's in your center, the major cause of death. What we found, the cardiac ion overload due to, and we found a young patient died with cardiac ion overload. The second cause of death in our center over the 14 years is infection due to splenectomized, and the youngest patient was 10, and the eldest patient was 18, which is a very young. Then there is endocrine complication and other. So we go to the more important question, is serum ferritin an accurate assessment for hepatic and cardiac ion overload? We report a case, 15 years old, Saudi patient, thalassemia major, transfusion dependent, and he was followed in our center for since he was 1 year of age. And in that time he had on this The chief complaint was